Hello, I'm David Healy, and this is a talk being given in Reno for a meeting organized by David Antonuccio, and it's October 4th. And I was given the title Medicine in Crisis: How to Talk to Your Doctor, which is close to what you're going to hear about, but it's also, you can get the text of the talk on a blog on davidhealy.org called Health, Care, and Science in Real Life. Okay. I was in Houston um, for the bicentenary. That's 49 years ago. There was a group of us there. We were all doing jobs, trying to get money to pay for our way going through college. And Houston just opened up what it claimed was the Big Dipper with the biggest, steepest drop in the universe and in history. And one of the guys said, for the bicentenary, we should take a ride on this dipper. I hadn't ever been on a dipper before, and I was paired in this compartment for two people with a guy called Greg, who was the coolest dude I knew who had been on dippers before. And Greg said to me when we just were about to take off, he said, when we get to the top of this, you are going to be petrified. I was a little surprised at this. Uh, when we got to the top, I have to say, though, I thought, we're dead. And I can't remember anything that happened after that. This talk is going to be a little bit like a Big Dipper. Uh, it's going to jolt anyone listening into it, but it's not going to give you as much of a jolt as Kim Witzak, whom you see here with her husband Woody, had when Woody took a ride on a Zoloft Big Dipper uh, and ended up dead. This is a jolt for Kim, and it's what happened to Kim and Woody that's at the heart of this talk. I need anyone listening in to not have a near death um, experience like mine, but to be able to get off the ride and do some thinking about what is it we can do to help people keep safe when they take a drug-induced dipper ride. And this talk has been given on the 249th and a half anniversary of the Declaration of Independence. In 9 months' time to the day, we'll have the 250th anniversary of the Declaration of Independence. And I'm hoping in the wake of the talk, some of you will conceive of some ideas that we can do to help keep people safer when they're on these rides. So let me begin by taking you all back to the 1980s when the NIMH, that's the National Institute for Mental Health, run a trial comparing antidepressants, the first antidepressant, imipramine, with cognitive behavior therapy, CBT, and interpersonal therapy, IPT, who are new kids on the block. And because there's a drug involved, they have a placebo pill. And because there's therapies involved, they figure they've got to have a placebo relationship also. The result of the trial was that imipramine beat the relationship placebo only in severe cases. CBT and IPT didn't beat the relationship placebo. Uh, and if you think about it, imipramine was a much stronger antidepressant than the SSRIs are now. So any of the SSRI antidepressants or the antidepressants that get used these days wouldn't have come out well in this particular trial. Nothing, it seems, would have beaten relationships slash possibly a placebo pill, which kind of suggests, all things being equal, that we do better getting better on our own, under our own steam, are when we care for each other. Now, the people behind CBT pointed out that, well, actually, when people had CBT, they were less likely to relapse. But of course, if they didn't beat relationships and placebo in the first instance, it really wasn't clear what that meant. And it is the case that antidepressants, even good and strong ones like imipramine, can have some withdrawal problems. And SSRIs can have even more withdrawal problems. So you are going to relapse unless you stay on the SSRI for the rest of your life. Now, you can understand, I mean, I can understand and you can understand, we can all understand people who say, well, if these drugs don't beat placebo, they can only harm you. If they have to beat placebo in order to have some benefit against which to put the risks of treatment. And if there is no benefit, well, they can only harm you. And even if you have a short-term gain, you may in the long term be worse off. But cognitive therapy isn't going to harm you, is it? Well, when you get a drug, in order to get a drug these days, most doctors say to you something like, well, you've got an abnormal serotonin system, or else they'll say you've got a chemical imbalance. And what these pills are going to do is they're going to put these things right. They're going to say to you, in essence, that you've got a broken brain, and our treatment's going to put that right. But CBT and IPT, well, it's actually wrong that the SSRI treatments are going to put that right. They're going to give you an abnormal serotonin system that you didn't have before you began the treatment, and it may be permanently abnormal. But CBT and IPT give you a broken mind. Behind CBT is the idea that you're not thinking properly, you're illogical. And behind IPT is the idea that your interpersonal skills aren't really up to scratch. And this is what the therapies aim to improve. But one of the oddities about the NIMH trial was it showed that the people who had the least cognitive distortions to begin with did best with CBT. And the people who had the best interpersonal skills to begin with did best with IPT. So the treatments didn't seem to be fixing anything that was actually wrong. They were maybe helpful, but they weren't actually fixing anything that was actually wrong. It's a bit the same with SSRIs, as you're going to hear. They work on a normal serotonin system. So anyway, behind this is a deeper issue, which is roughly 9 out of the 10 treatments that we give across medicine, whether it's for hypertension or diabetes or lipids and things like that, including the antidepressants and all the pills used for nervous problems, aren't treating a problem in you. They're being given for something that's probably better viewed as a political problem, a problem in us, the way we have our social relationships organized and things like that, the type of food we eat and things like that. It's very convenient for the politicians, however, to locate the problem in you. So as opposed to just being given an abnormal mind and brain, you're being told that there's problems in you that need to be fixed when in actual fact, there aren't. And you're not going to be helped to fix the wider problems by thinking that they're based in you. Okay, that's a little airy-fairy, you might say. SSRIs cause people to commit suicide. They can cause people to commit homicide. You get hooked to them. They can wipe out your ability to make love for the rest of your life, even after you've halted them. CBT and IPT don't do anything like this, do they? Well, when therapists begin CBT, if things don't work out, they don't give up. They refer you, well, they begin IPT, perhaps, or DBT, or FBT, or whatever. And then they'll refer you on to a doctor like me, who may put you on an SSRI, which can cause you to commit suicide and homicide and interfere with your ability to make love, and to which you can get hooked on, which you may never be able to go off. But there's also something else that they can do. And it's this, that during the 1980s and 1990s, therapists practicing CBT recovered memories of abuse that never happened. This led to loads of families being destroyed. It led to people who hadn't done anything wrong being put in jail. It led to suicides. It caused other problems as well, in that what you had, and what I've seen in real life, was you had perfectly sensible therapists saying to me, we have to believe the patient, which of course is an important issue. But when the patient says, I was abused on an alien spaceship at the age of 1, it's a really interesting issue about whether believing the patient is actually going to help their sanity or not, and whether it's going to help teamwork if I'm being told, if one of the people that the therapist is working with is being told, you have to believe this patient when they say they've been abused on an alien spaceship at the age of 1. This came to an end to some extent because of legal actions showing the therapists had created these memories. But it hasn't gone away. We've now got trauma-informed care. We've got complex PTSD labels being given to people. And these things are rather like the low serotonin and chemical imbalances. They're slogans. We've got biobabble on one side, we've got psychobabble on the other. And this really isn't doing any good to anyone. And there's a further issue here. Well, you might say to me, look, recovering memories of abuse that didn't happen and given diagnoses like complex PTSD and using slogans like trauma-informed care are not part of CBT per se. But, Woody Witzak, Kim's husband, committed suicide on Zoloft. He hadn't had any mental illness of any sort. He was put on the pills by a decent doctor. He complained and told the doctor that things weren't right. He'd only been put on the pills, I should mention, for a few nights poor sleep. He didn't have a mental illness of any sort beforehand. He told the doctor things weren't working out right. The doctor said, you really need to continue taking these things. They can take 6 weeks to work. If Woody had been taking a potent serotonin reuptake inhibitor like chlorpheniramine, which can cause you to commit suicide and homicide, and you can get hooked to it, and can interfere with your ability to make love, he'd be alive today. Why? Because it's available over the counter, and he'd have been in control of what was happening. And if after 2 or 3 days in this pill, things weren't working out right, he'd have stopped it. The problem was his doctor, trained to think that these drugs can take weeks and weeks and weeks to work, said, no, you need to continue taking them. And lots of doctors will say, maybe we need to even double the dose or add other pills in. Or if you begin saying, look, I've got strange thoughts going through my head I've never had before, they may think about detaining you in hospital. But that's a practice issue. It's not just being caused by the pill. It's the fact that you have to get these pills through a doctor. And it's the same with CBT. The actual ideas behind CBT may be quite clean, but you're getting them through a therapist, and that's where the problems can start. It's a case of saying, perhaps, Houston, we have a practice problem. Okay, so that's one aspect of the problems we have. There's a further aspect. On the 225th anniversary of the Declaration of Independence, an article which I call Study 329 got published. And this is a trial of Paxil in teenagers who are depressed. And it claimed that Paxil works wonderfully well for teenagers and is completely safe. Turned out that Paxil didn't work all that well for these teenagers, that the company knew it hadn't worked in this trial, and it turned out that it wasn't safe, that it could cause these teenagers to become suicidal and try to kill themselves and have other behavioral problems. It led to a fraud charge against GSK. It led to a $3 billion fine for GSK. Despite all this article has been unretracted. It's still there in the journal in which it appeared. It can cost you $41 to download a copy of the article. And Elsevier, who are the company who owned the journal in which the article appeared, make $3.5 billion per year from articles like this. And this isn't an unusual article. What's happening in this article applies to all company studies of all medicines across medicine. Now, psychotherapy and CBT doesn't have a problem like this. They don't have ghostwriters writing these articles and putting the names of prominent therapists on the articles the way pharmaceutical companies put the names of prominent academic doctors on the articles. But I was holding a grant for a cognitive therapy of delusions project 30 years ago. And we had two big name cognitive therapy gurus on the grant application, and this is perhaps why it succeeded. And we were able to show using rating scales that giving cognitive therapy to some of the patients who were deluded, who we entered into the study, seemed to work. There was a change in the rating scale, which you could say, well, this is a benefit. One of the points of the talk is rating scales they live in a virtual world and not true in the real world necessarily. And in the real world, these patients didn't show the same change. The benefit, if there was any, wasn't sustained. And I figured after the article that we wrote that said cognitive therapy works, after that had come out and it become pretty clear that it didn't really work, I said to the gurus, we need to write an article saying that it doesn't work for severe cases like this. And they refused to do so. What you need to know is a huge amount of the psychotherapy literature, the trials that were done, that has been left unpublished also. It may not be fraudulently written to say that, well, this treatment did work, but leaving them unpublished leaves us all unclear. We're left thinking that maybe these therapies would do more than perhaps they actually can. But this is not just a psychotherapy issue. Treatments like transcranial magnetic stimulation or other neuromodulatory techniques, for which is the big fashion these days, again are claiming things like, well, we can replace electroconvulsive therapy, for instance, when in fact they can't. The people behind these treatments have all tried to use them in severe cases, have found that they didn't work, but they leave the published literature that there was a benefit in milder cases out there, which means that there's a flourishing industry in using these technologies for mental health problems. Something linked into all this is that during the 1950s, we had a condition, a serious condition, very serious condition in children in particular, called rheumatic heart disease. It's vanished, probably because we overused antibiotics, the kind of thing we're told not to do. Back in the 1940s and 50s, about a quarter of the people in some of the large old mental hospitals had a condition called catatonia. It's vanished, probably because we've been overusing a bunch of drugs we've been told we shouldn't overuse, the benzodiazepine type drugs. Puerperal psychosis, the classic puerperal psychosis, has also vanished, and nobody's trying to work out what do we do right that's caused this to disappear. Schizophrenia is much less common than it used to be, and similarly, no one's asking what's going on here? What's the reason why we're not seeing this problem as much as we did before? And part of the reason this is all happening is we used to make weapons in order to fight wars, but after World War One in 1918 or so, people began to realize that, the arms industry did very well out of this war, and we began, in a sense, to make wars in order to sell weapons. In the same way, in the healthcare arena, we used to make treatments to, to cure diseases, but somewhere around 1990, with the SSRIs, we began making diseases in order to sell treatments. Depression used to be a rare disorder, very rare disorder. With the SSRIs, it's become the most common disorder on earth, the greatest source of disability on earth. And this is because we've been making depression rather than curing it. So there's no one really in the healthcare system that has an interest in getting you well. Now, let me move on to one more angle on this, which is 4 years ago, I was asked to review an article for a very prominent journal, Social Science and Medicine. And the article was good. It was by two psychiatrists in the UK, Joanna Moncrief and Mark Horowitz, who are highly thought of by everyone, particularly by psychologists. They're almost happy for these guys to be viewed as honorary psychologists. And the article said there's nothing wrong with the serotonin system in people who are depressed. But when we've looked at the most cited articles in this area, 29 of the 30 most cited articles claim that there's a well-known and well-established problem in the serotonin system of people who are depressed. This is very odd, they said. So I reviewed the article for the journal and said for the editor, yes, they're absolutely right. There is no evidence that there's anything wrong with the serotonin system of people who are depressed. We never really thought there was anything wrong. Uh, but you can kill two birds with one stone here. The reason 29 of the 30 articles all say there is an established abnormality, and they cite each other, is that these articles are ghostwritten. Uh, this is a marketing trope that's been put into the article without any basis to it, but that's what ghostwriters do. That's the role they play. They write the study up and they add in some key marketing points, and they cite each other. And the editor thought this was neat, and she asked the authors to include this point in their revision of the original article. But they wrote back and said they were too nervous to do so. And she got in touch with me and said, look, we'd like to publish your review along with some references added into it, alongside the Moncrief and Horowitz article. I said, fine. And I did exactly what she asked me to do, complete with references. But I added one sentence, and I knew this was going to discombobulate her so much that she wouldn't publish. And the sentence was, everything that I've just said about the SSRIs here holds true for the COVID vaccine trials also. They were ghostwritten. There's no access to the data from them. People in these trials were injured and have been eliminated. They've been removed from the picture. And that did discombobulate her too much to publish. She didn't publish. Now, here's the point. I've maybe a bit unusual here. I've had several friends, including co-authors of articles, who have been given the vaccine and died shortly afterwards, within a few days of having had it. And there's really very little doubt but that the vaccine killed these people. I know no one who's died from COVID. I may be unusual in that way. I know several people who are friends now who are so enthusiastic about the vaccines that they entered the trials as participants and were seriously injured and have been written out of the script. I was working in a clinic in person, not virtually, through the pandemic, where everybody had to be vaccinated. And it was clear that some of the staff in the clinic, the staff now, the people who knew the doctors who were giving them the vaccine, were injured by the vaccine, but their friends told them, their doctor friends told them, no, this didn't get caused by the vaccine. You need to take the second dose. This is exactly Woody's problem. He was told by the doctor, keep on going. And, the vaccine, the COVID vaccine story is really the SSRI story being replayed. Now, I've never hinted to anyone that they shouldn't have a vaccine. I've never asked for any drugs like the SSRIs or anything like that to be removed from the market. My problem is our ability to be confident in the treatments that we give or that we take. And we need an ability to say, look, I'm a little wary about all this. I need to think about it and things like that, rather than being dragooned into something. And the situation is a little bit like, in some respects, with any therapies, whether the psychotherapies or vaccines or drugs or whatever. It's a bit like the situation in Europe 80 years ago in Germany, where a bunch of people were told, look, there's a fuss in Western Europe which we need to sort out. We're going to put you on trains and send you to work camps out east for the moment until the fuss is over, and then maybe you can come back. And while a few people did resist, 95% of us get on the trains. We figure this a bit odd. It's maybe not quite right. We also think someone up there is going to realize that a mistake is being made and is going to turn things around. After the fuss in Western Europe was over and people came back, a bunch of people moved to Israel from there, and they weren't met with sympathy, the kind of sympathy you might expect now. They were met with a question, which is, why didn't you resist? And that's an issue for all of us when it comes to healthcare and the things that we're offered. Why don't we resist? In order to get to grips with what's going on here, let me just give you a quote. It's from a poem called Kubla Khan. It's by Coleridge, who says about well, what I want you to do is to think about this in terms of therapists, doctors. Beware, beware, his flashing eyes, his floating hair. Weave a circle round him thrice, and close your eyes in holy dread. For he from honeydew hath fed, and drank the milk of paradise. That's a little bit of the problem we've got with healthcare. The guys and girls in it are drinking the milk of paradise, and we need to be wary of them. Now, what is the milk of paradise? That's at the heart of what this talk is trying to pin down. Let me take you on to the dipper. After a few minor dips that you've just had, um, look at this here. This is the ascent. And it's slow. And this is, at this point, Greg became a gibbering wreck. I didn't because I had no idea what was going to happen at the top. And you don't with the rest of this talk. But this bit of it's slow. So we've got time to ask, where did the SSRI group of drugs come from? And what do they do? How do they help us? And the answer is very, very curious. They came from a bunch of Freudian analysts, the last people on earth you would think are responsible for the SSRIs. And how it happened was this. Back in the 1960s, when the analysts were doing therapy with people who were depressed, among other things, some of these people had been put on imipramine or some of the other early antidepressants, first of all. And the analysts could spot a change in what they called the transference reaction. They could also spot that some of these patients, when they went on an antidepressant, became suicidal. And you take the pill away, and they weren't suicidal anymore. You give them the pill back, and they became suicidal again. So these analysts were saying these pills can make you suicidal. When doctors today can't even see a healthy volunteer put on these pills become suicidal. The idea that it's the depression only that causes you to become suicidal was something the analysts could see was clearly not right, and doctors now can't. The analysts could see people who are severely depressed who lose libido and lose the ability to make love. When they went on the pills were also causing a problem, a further loss of libido and a further interference with our ability to make love. And doctors today can't see this, even in healthy volunteers who have no problems making love and have loads of libido. And the only difference is they've gone on these pills. So there's something unusual going on. And the key thing that's really unusual is this thing about the analysts spotting some of these older antidepressants cause a change in the transference reaction. Listening in to these conversations was a man called Arvid Carlson, who wasn't a doctor, but he listened to doctors and he heard them say this, that it happens on some of the antidepressants and not others. And he said, this is interesting. The ones you're saying that cause the transference reaction change act on the serotonin system, and the ones that don't cause it don't act on the serotonin system. So let's make a pure serotonin reuptake inhibitor and see can we work out what it is that these drugs are doing. And the answer is that what we'd say today is they reduce emotional reactivity. Now, I need to show you something here. Uh, Carlson didn't think he was making a magic bullet that was going to fix the serotonin system. He didn't think there was anything wrong in the serotonin system. No one thought there was anything wrong in the serotonin system. He thought, as with almost all drugs in medicine, that he was giving a therapeutic principle, which is something that can act on a normal system, just like LSD acts on a normal serotonin system, but that can cause good trips, which may be useful, and bad trips. In the same way, he figured SSRIs could be helpful for some people, cause a good trip, and bad for others, cause a bad trip. If you asked him, could the bad trips mean that people become suicidal? He said, yes, that's exactly what it means. So let me give you a better feel for therapeutic principles. This is a picture of constipation, four different kinds of constipation, and four different laxative therapeutic principles. You can add fluid to the bowel. You can add bulk to the bowel. You can stimulate the bowel. You can relax the bowel. And all of these things can be helpful for certain kinds of constipation. And your great grandmother and an old style family doctor used to be very good at being able to work out, listening to you and things like that. They were able to work out what was likely to be the therapeutic principle that worked for you. And the reason to get it right was, well, if we put you on the wrong one, you could end up with treatment-resistant constipation. And some people did. When a company gets the rights to use the word laxative, however, they don't give you any advice about exactly what kind of constipation to use their drug in. They don't mind if every kind of constipation gets their drug. They don't mind if you're on four different kinds of laxatives, provided one of them is theirs. And this is a route to treatment-resistant constipation. That isn't as benign as it sounds, but in particular, we've got a problem. This applies across medicine. It's the same with antihypertensives. There's at least four different therapeutic principles. It's the same with anti-diabetic agents. It's at least four different therapeutic principles. It's the same with painkillers. It's the same with back pain. It's the same with mood disorders. And if an SSRI, which is one of the things that can help certain mood disorders, isn't the right one for you, it can cause treatment-resistant depression. And increasingly, we've got people with treatment-resistant depression caused by SSRIs for which we've got no known cure. We do not know how to sort this out, opting for euthanasia because the condition is so much worse than the original condition. So this is not immaterial. Now, before we go on to the therapeutic principles behind drugs for nervous problems generally, let me just say these apply to psychotherapy also. When Freud began, he had a simple therapeutic principle, which was when women come in and say they've been sexually abused during childhood, believe them. And then one day in the clinic, a lady threw her arms around him and he was discombobulated. He didn't decide to go with the obvious idea. He said, maybe she thinks I'm her father. Maybe she's fantasizing. And this is what he called a transference reaction. And then he began thinking, well, maybe all those cases of women I thought were sexually abused before weren't actually sexually abused, but they were fantasizing about their father. Now, if he had two therapeutic principles that he held on to, one is believing people, and the other is saying, well, actually, it's all just fantasy, that might have been fine if you had two different principles and applied them when each of them looked right. But he switched completely from black to white to thinking all of the abuse is just fantasy. He became unable to recognize abuse. So Freud 2.0 really wasn't as great an option as, we thought we had, but it was a wonderful option for pharmaceutical companies and politicians. In the case of pharmaceutical companies, they've put a lot of work into building up FDA and other drug regulators as our father figure. They figure we need a father figure. We need someone to delegate our narcissism to, in Freudian terms. Someone who's going to keep us safe. And that's FDA. So if FDA have approved a drug as working and as safe, and someone like Woody gets put on it, and it isn't working, and he's rolling on the floor, holding his head, saying, you wouldn't believe the strange thoughts going through my head, he's fantasizing. That's how companies expect us to start thinking about what's happening to him. It's very Freudian, and it's deliberately Freudian. And Jung, one of Freud's younger colleagues, said, this is crazy. He's applying the one principle across the board to everyone, but people aren't all the same. There's extroverts and introverts. Extroverts, when they get anxious, share the problem around. Introverts, when they get anxious, retreat into their own head and make things even harder for themselves. Now, that may sound terribly mental to you, but in fact, if we give you a personality questionnaire measuring out your extroversion or introversion, we can predict how much anesthesia it will take to put you to sleep for surgery. Extroverts need much less than introverts. Similarly, extroverts, like Woody, respond poorly to SSRIs. Introverts respond much better. Not all introverts, but just on the whole, much better. Extroverts these days, you don't hear the word, they get labeled as having ADHD. Adult ADHD does not exist. These people are what used to be called extroverts. Introverts are now called autistic spectrum disorder, ASD, and this is a terrible pathologization of normal variation. We need people to be different. You're not going to have good marriages unless opposites attract. You're not going to have good workplaces without a range of different skills. You're not going to have good teams as rugby, soccer, whatever, where you got to have people who can score the points or the goals, and you got to have people as well who know how to stop the other side being able to score. These are different skills. And if we pathologize these and get everybody to conform to some mid-range, we're going to be worse off. There's a further point here, which is that extroverts were much more likely to recover, and not just recover, but relive memories of abuse that never happened. And CBT in the 1980s and since still has been poor at recognizing the differences between people. And this is partly why they ran into the kind of problems that they did. CBT, like Freud 2.0, has tended to be, one size fits all option. You've been illogical. We want to remedy your logic, your thinking style, or whatever. In fact, there's actually some good points within CBT, some different therapeutic principles within CBT. You've got cognitive restructuring, you've got problem solving, you've got behavioral activation. These are all three different things, only one of which might apply to me, for instance. The behavioral activation is the one I'd guess might help me, and the other two might just annoy me. But a therapist doing CBT by the manual is going to throw them all at me rather than, listen closely and get a sense of what might work for me. So that's therapy. I actually should say one more thing thrown into the mix about CBT. Uh, as I hinted earlier, they've got a bunch of slogans. We've now got slogans like trauma-informed care and complex PTSD. These are just slogans. They're not, I mean, again and again, people with CBT, who've been on CBT referred on to me. I get told, the diagnosis is complex PTSD. This is not looking at, the person. When I go through the history and find there's very little that really matches up to that, you realize you're dealing with a bunch of slogans, a bit like the low serotonin slogan. But here's the point I want to really get onto, which is the masters of all this. While on the one hand, they sell magic bullets, on the other hand, the pharmaceutical industry are terribly good at recognizing therapeutic principles. They don't call them that, they call them marketing principles. And they have four different marketing principles for four different groups of doctors. They figure we aren't all the same. And the point here, if you missed it, was, they're looking to market to the consumers of drugs. And you are not. Anyone who's on drugs, anyone who could be a patient, is not the consumer of drugs. I and other doctors are the consumers of drugs because the company makes money when we write a prescription, not when you take your pills. So, in what you're looking at here is a very small number of consumers. In the United States, for instance, possibly one in every 400 people is a doctor. But there's more money being spent on shaping how doctors think, the one doctor, than on all other consumer products for the other 399 people in the United States. And it's aimed at ensuring doctors don't have a thought in their mind that's not put there by a pharmaceutical company. It's not money handed over. Doctors haven't been handed huge amounts of money because they say that doesn't influence them. They've been handed what they say does influence them, the evidence, which is ghost-written and often fraudulent. So let's leave therapeutic principles behind for a moment, now that I hope you get a sense of what they're about, and look at the drugs we use for nervous problems. Um, let's take people who are anxious. There's a few different treatments we can use. One is benzodiazepines, the other is beta blockers, another is nicotine. In the case of the benzodiazepine group of drugs, what these do is they relax your muscles. So my brain looks at me giving this talk and thinks he's got relaxed muscles, so he can't be awfully anxious. Uh, the brain has been fooled. The action's on the body. The beta blocker group of drugs slow your heart rate. And if my heart rate's slow because I'm on a beta blocker, my brain thinks that he's not anxious giving this talk when maybe I am. But again, it's a case of the brain being fooled. Now, did I say nicotine? Well, I did. SSRIs reduce emotional reactivity. And that's better for obsessive compulsive disorder, OCD, than it is for treating people who are depressed. And Oliver Carlson was pleased with this and maybe a little surprised when a clinical colleague came up to him one day and said, you know, I've got a bunch of patients with obsessive compulsive disorder who say they do better smoking nicotine than taking your SSRIs. And his response was, well, you know, let's do a trial and see. And the answer that came out of the study was yes. There's a bunch of people who've got OCD who do not do well on SSRIs and are much likely to do much better smoking nicotine. Now, there's a few points here. One of the points is people, when they smoked, uh, tons of people smoking, didn't just do it, because they got hooked to nicotine per se. It was often because they said it actually did calm them down. I mean, this is true for not just OCD, but for people being anxious. If you've got OCD or you're anxious, and the issue is a choice between taking nicotine and SSRIs, neither will work for everyone. But if it's you, and the issue is you choosing which to take, who's the best to consult? Is it FDA who haven't licensed nicotine? Is it your doctor like me who doesn't smoke? And as you'll hear, I've got one more reason for not being enthusiastic about it. Or is it you who are in a position to test nicotine out and see what it does for you, if anything, and test the SSRIs out and see what they do for you, if anything? You'll know the hazards of nicotine. I can tell you about the hazards of SSRIs and say they're just as likely to kill you prematurely the as nicotine would. My view is it's you're the person best placed. Now, I'm not advocating nicotine here. My father died from lung cancer because he smoked from a young age, and he died prematurely. The fathers of lots of my friends died prematurely from heart attacks or lung cancer. But the issue is, back when I began training in medicine first, it was acceptable to say, you know, the art of medicine involves bringing good out of the use of a poison. If we put nicotine into that phrase, you know, the art of medicine may involve bringing good out of the use of nicotine. You can, I mean, I figure lots of people listening in today would say, well, yeah, we can see that point. But on the whole, if I just say the art of medicine involves bringing good out of the use of a poison, I get people holding up a crucifix and garlic in front of me and hissing at me because they don't accept that any of our drugs, the SSRIs, the antipsychotics, whatever drug you care to think of, could in any way really cause much harm the way nicotine can. But they do. They can cause just as many years of life lost as nicotine, if not more. So there's been a change in medicine from having the common sense to view these things as something we should be maybe wary about, to viewing them as we can only do good if we have more of them. And there's a point to add in here. You know, psychotherapy is not free of this problem. the art of psychotherapy involves brainwashing, out of which we might be able to bring some good. And we need to be very careful that we let a therapist of some sort who may have their own problems start brainwashing us about what our problems are when they may not be our problems. Uh, so let me move on from here to come back to the exercise and how is it that they fool the brain? And the answer is that, well, I'll put up the next slide just to change things around a bit. The answer is that they don't act on our brain. There's very little serotonin in your brain and mine. Only 5% of our serotonin or less is in our brains. 95% is in the sensory receptors of our peripheral nervous system around our body, in our skin in particular, and our gut, which is part of our skin. Our gut is outside our body. Plus our joints, plus our eyes and inner ears, which help us keep balance and things like that, along with our joints. That's what the serotonin is. And LSD works on this, and SSRIs work on these. LSD famously opens the sensory gates and floods our brain with a bunch of images, and SSRIs do just the opposite. They close the gate and reduce the image flow. LSD can come with problems. When you get a flood of images into the brain, the images at a controlled rate are what Daniel Kahneman called our fast thinking. We keep an eye on what's going on in the environment based on prior experience and things like that. We jump to ideas about what's going on, and that works. It keeps us safe. Every so often, we get things wrong. We need to think slowly. And often, our slow thinking bit of our brain, the problem solving bit, gets things even more badly wrong. But when you flood the brain with a ton of images, you pass by that gate control, and the brain often gets it terribly badly wrong. You think you've met God, you think you've seen the afterlife, you think you've witnessed your Aztec or Irish or Jewish ancestors been killed or whatever, and figure that that trauma is affecting you now. If therapists who are often increasingly married to treatments that will do this don't realize what the treatments are doing to produce these ideas, it's a recipe for disaster. In the case of the SSRIs, the problem is just as bad. And if you think about SSRIs in terms of a sensory deprivation tank, where you reduce sensory input drastically, we know people go mad in these tanks. In the same kind of way, if you reduce the sensory input to the brain, you won't do a flood of images, but just having much less imagery can be as big a problem. You can end up with a dominant image. And having seen lots of people who've killed their children, killed a partner, done other weird and strange things, and you ask them almost, I mean, if you ask them early on, straight after the event, why did you do this? They'll often say, I don't know. Just the thought was there, the image was there, I was compelled to do it, I was on a train track. My usual, I mean, I've had thoughts like this before, but I think about this is crazy. I problem solve, I sort things out. But this time around, nothing clicked in to stop me doing this. It's a little bit like hypnosis. And it's something that we don't really take account of in the way we should. Now, hopefully you can appreciate this is not saying don't use SSRIs. This is saying a bit like LSD. I'm not saying don't use LSD. All of these things can be put to good use, provided we're letting you know what we're doing and what the risks are of what we're doing and what we're aiming to achieve. In the case of the SSRIs, it's just the right amount of sensory reactivity reduction. So when you've got OCD and you notice all the kids' stuff is around the place, thrown around the place, and they haven't tidied up, and normally you get very bothered about this. If you're on an SSRI, maybe you sail past it without too much of a problem. But part of the problem here is that LSD, we just take it briefly. It lasts maybe 12 hours, and we don't repeat it every single day of the week. With an SSRI, you may be repeating it in a toxic dose every single day of the week for months or years. And that can break the serotonin system. And a lot of people, when they get off these drugs, complain of brain fog. And it leaves them convinced that the problem is in the brain. They've got a broken brain. When we test how your brain's working, it works fine. It works normally. There's no evidence that it's broken. And what they're really telling us is their embodied knowledge is broken. And it is. That's where the break is. It's like if you're an elite pianist or an elite athlete that needs to be able to coordinate really, really well. And you're on an SSRI and the coordination breaks down. And let's say you've taken the drug for too long and it doesn't bounce back to normal, and you're not playing the piano right and your golf swing's not right or whatever, uh, you're not going to put that right by concentrating or attending, which is the way we often try to solve problems. And that's effortful, and that's what leads to the experience of brain fog. In actual fact, it's a bit like children walking. They don't have a program which tells them how to walk. They try it again and again. They fall over, they try and copy brothers or sisters or others in the nursery or whatever. They keep trying until they begin to get it, until the information, the knowledge is built into their body. And maybe they pick up a virus at nursery and all of a sudden they're flat on their bottom again. They can't walk anymore and they need to relearn it by blunt repetition. Now, there's a point behind all this, which is there is a therapy that may help people who have SSRI withdrawal problems or post-SSRI problems. And this is called interoceptive therapies, which are people working with you to get you to recognize what your body is doing, the knowledge in your body, and where it's not working right, and working on things to help you put that right, maybe by exposing you, getting you to repeat the things that you haven't been doing well again and again and again until you start doing them better. Problem at the moment is the way healthcare works. If you've got someone trying to do that with you, you've probably also got someone who figures, well, you're anxious because of all this, and an SSRI is the perfect treatment for your anxiety, or you may be put on antipsychotics. So the people doing this, and who are unlikely to want to think that an SSRI can't help you or an antipsychotic can't help you, are pouring flames on the fire that the interoceptive therapies trying to put out. That's not a recipe for success. So when just short of your peak experience, this is just as we round the bend towards the big drop. And let me quickly tell you about a study we did 25 years ago or more to see was Arthur Carlson right about SSRIs? Could people who took an SSRI distinguish something they did from drugs that are not SSRIs? And we took 20 doctors and nurses working in a mental health unit and randomized them either to Zoloft, Woody's drug, or to a non-SSRI and crossed them over after 2 weeks to the other one that they hadn't done. We didn't know which they were on. And the answer was Carlson was right. People taking the Zoloft could pick out the SSRI effect. And they were able to put in words, yes, this is a reduced emotional reactivity, except in two people who became suicidal on Zoloft, not on the other drug. And this fitted in very well with a trial Pfizer had done 20 years before that nearly, where they'd given Zoloft to a bunch of women, healthy volunteers, and every single woman dropped out of the trial after 4 days. It was due to go on for 2 weeks. They dropped out after 4 days because they were too agitated by the Zoloft. And Pfizer wrote it up and said Zoloft can cause this. So our volunteers were not unusual from that point of view. But the most interesting observation that came out of all this, and at the heart of the problem we now have, is that 24 hours into the experiment, one of the patients in the unit came up to me and said, is Dr. X on a drug? And I said, yes. I mean, the patients didn't know what was going on. Okay, so I said, yes, he was. And he said, is he on an SSRI? And I didn't know because they were all blind. But when we broke the blind, it turned out the patient was right. That the patients in our mental health units can recognize the effect of these drugs almost instantly after you go on them in a way that the mental health staff, the experts, supposedly doctors, nurses, can't. They don't spot the changes that these drugs almost immediately cause. Now, you're told these drugs may take 6 weeks to work. That's all wrong, as you're going to hear. The key thing is they work within, well, in the case of some of the key things that they do, they work within an hour. Within an hour of taking your first pill, you will be genitally numb, and that's not happening in your brain. That's a reduction in the erotic sensitivity in our genitalia, and it happens almost instantly, and it can be put to good use. So there are things like this that you and your family and your friends are able to recognize and probably seeing, but therapists, psychotherapists, medical therapists, nursing staff, and others in units don't spot, which is terribly curious because the reason we have SSRIs to begin with is therapists once could spot this. Some things getting in the way of us being able to spot the obvious. Okay, when I said you're going to have a peak experience at the top, you probably thought the word was P-E-A-K, that you're going to be standing on a mountaintop and would have a view around the surrounding landscape. No, the word I was using was P-E-E-K, which is you're going to peek through your hands to some cracks in your hands at something you can't really bear to look at and hope is not really there. And that's what's causing Woody and you and me and all of us problems. And it's we're dealing here. Woody was dealing with, but didn't know he was dealing with, and Kim didn't know she was dealing with, a religion, not a science. Woody had a good doctor called Chris Armstrong, a decent man who was shocked at what happened at Woody, but was keeping to the standards of care and the drug labels and things like that. He was following these things. We follow religions. Science is about experiments. And when I give you a pill, there's nothing to follow. There are things in books that may be helpful, but there's nothing that should be followed. The experiment starts when you take a pill, and I and you are supposed to keep a close eye on what's happening to you. In the case of health, we've got a health religion now. We used to aim at people being holy. Everybody now increasingly aims at being healthy. Um, Religions, however, in a sense, aren't about getting us either to be healthy or holy. They're about keeping the herd together, the tribe together. They're about slogans, badges of identity, like CBT and SSRIs, like Catholics and Protestants. These days, we don't confess our sins. We confess our ADHD, our ASD, and trauma, and everybody welcomes us back into the community. Religions tolerate abuses, like sexual abuse of children by clergy, like medical abuse of people like Woody by doctors, by the pills they give. And they tolerate these things because religions offer magic principles that help keep order in our lives, give us a shape to our lives, and we're very reluctant to let go of that order. In in the case of healthcare, we've borrowed two magic principles from Catholicism. One is sacraments, and the other is infallibility. Sacraments are just the opposite to poisons. There's something that can only do good and cannot do harm. The great irony, though, is the Eucharist, which is supposedly the real body and blood of Christ. The church has been forced to recognize that even though it's the real body and blood of Christ, it's no longer the piece of bread, that it still contains gluten, and the gluten can harm some people. This has really caused serious problems in the Catholic Church. Uh, the Eucharist is less of a sacrament these days than our pills are. What makes our pills sacraments? Well, it's drinking the milk of paradise that causes this. It's randomized controlled trials and evidence-based medicine. And you hear these words, intoned in reverential tones. Let me explain. The story started 35 years ago, and here's a point. Religions are things we followed. There may be things we've followed for 2,000 years. There may be things we've followed for 100 years. In this case, the religion began 35 years ago. when three Boston clinicians reported on six patients who became suicidal on Prozac. Within a year, lots of other groups had reported the same things in articles appearing in medical journals. There was no doubt but that Prozac can cause you to commit suicide. Eli Lilly's response, which created evidence-based medicine, forget the other stories you hear about where evidence-based medicine came from. If it didn't suit the pharmaceutical industry, we wouldn't have heard these words. Lilly said in response, we've meta-analyzed our RCTs, and these show that Prozac does not cause people to commit suicide. There's no evidence there that it does. In fact, when you get the raw data, there's abundant evidence that it does. This was pretty fraudulent. So Lilly, the key moment though, was Lilly branded randomized controlled trials as the science of cause and effect. And the views of doctors who'd written up the papers saying that Prozac can cause people and children to commit suicide were anecdotes. And that has stuck. The branding has stuck. Now, this is crazy, and it's extraordinary that it took hold and stuck. If you're on a jury and you're faced with, in the case of a man who may have murdered his wife, and his lawyer gets up and says to you, you cannot find him guilty because our randomized control trials and our epidemiology shows that men, even men with a criminal record, even men with legal and financial problems, even men with wives that no one likes, don't on average murder them. You'd say, that's crazy. Give us the details of this case, and we'll come to a consensus as to whether he did or didn't. And it's the same with all of the harms of drugs, whatever drug you care to think of. You've got to analyze the individual case, and you've got to have a bunch of competing views as to what may be going on and arrive at a consensus. That's how we work out cause and effect. That's how the pharmaceutical industry used to do it before this Prozac problem. That's the kind of thing FDA can't do for reasons you'll hear about. So the other aspect to this is when RCTs got introduced, nobody really took into account that they were averaging machines. LSD, we knew about good trips and bad trips uh, before RCTs came along. But if you put people on LSD through an RCT, you'd average out the good and bad trips and might end up saying, you know, the effects of LSD are just placebo, which is what a bunch of people say about the SSRIs. And this is a disaster. It causes us to figure, again, Woody lying on the floor saying you wouldn't believe the thoughts going through my head. It causes us to think that's Woody's illness. FDA have approved the drug. It's only a placebo. It couldn't be causing him to have weird and strange thoughts that he's never had before. This must be some part of his mental illness. So it's doing a great harm to people. And it's happening because you've got a bunch of doctors who don't know the drugs in the biblical sense of the word drugs. They haven't had the SSRI or the LSD or whatever. And this means that they're poorly equipped to work with you when you take these drugs. When you're on these drugs and have a good experience or a bad experience, you know what's happening to you. And these things can be good enough or bad enough that you know this is not all in your mind. But we have lost the ability to work with you to help get you to a better place or to get you to a useful place. How many people have a good and a bad trip? Well, in the case of Zoloft, strictly speaking, the trials for Zoloft didn't meet the criteria that should have let FDA license it. You have to have two positive trials. There weren't. In the case of the SSRIs as a group, 50% of the trials are negative. Now, it doesn't mean that all of those patients had a bad trip, or a load of patients in those trials had bad trips, but it's certainly the case that there were a lot of bad trips. We know that something like 5 to 10% of people dropped out of these trials for problems like Woody's, and then even more dropped out for other causes, other problems on the pills. We know that before doctors were trained to say these drugs take 6 weeks to work, if you looked, when they didn't say that kind of thing, when you looked at what people were doing when they got a script for an SSRI in the early days, we know that 50% of them stopped these drugs within a month. It's a bit like getting it over the counter. They kind of concluded, this isn't helping me. So there's a lot of bad trips in there, and so much so that when Zoloft was being licensed, some of the people in FDA said, look, shouldn't we let people, doctors, consumers, doctors, know how many negative trials there have been? It would help. It would give the impression that, these drugs don't necessarily work for everyone. FDA had an eminent squeeze called Bob Temple, who said, no, I'm not going to let you do that. How many good trips are there? Well, FDA at this stage have 100,000 people who have been through trials of these drugs and have analyzed these trials, and in particular, been able to look at the people who either in the really bad trials or in the good trials that let them license the drugs, look at how many people had a really stellar response where, you couldn't confuse this with a placebo effect. And the answer, according to FDA, is maybe 15% of people, 1 in 6 people, maybe 1 in 7 people have a good trip on an SSRI. What we're hoping you'll get when we give you an SSRI is something that most of you aren't going to get. So that's the problem. FDA knew this and knew that there was a sufficient number of people getting a good response that it was okay to license these drugs 35 years ago. This is not recent knowledge. They've confessed to some extent recently, but actually it's not particularly recent knowledge. So where does that leave us? Let me take you on to something that may give some of you a near-death experience, but breathe deeply. Here's some figures, and they're awfully simple figures. They're rounded up, as you'll see. This applies to all drugs we use across medicine: antihypertensives, drugs for dementia, drugs for diabetes, drugs for back pain, whatever. The cardinals of evidence-based medicine and RCTs say RCTs are magical. They control for all confounders in all known universes. And the answer is they don't. They don't control for the elephant in the room, the major confounder, which is our ignorance about the conditions we're treating. Depression, for instance, is a bunch of different conditions. It's not, they may look vaguely similar, but there's a bunch of different disorders there. It's the same for dementia. It's the same for diabetes. It's the same for back pain. Your back pain may be caused by an infection. That's a totally different disorder to other kinds of back pain. And what this does is, when we're as ignorant as this, and when people are going to respond differently to different drugs, like if you're given an antibiotic for your back pain, there'll be people who are going to respond much better than they do to painkillers. When we've got this kind of situation, you can use a problem a drug causes to hide a problem a drug causes. Now, that might sound quite mystical to you, but it's actually pretty basic. And I think I know the people who will have advised companies to do just this kind of thing in the case of the SSRIs. So up there on the top line, you've got this huge big trial of an SSRI, let's say. And looking at this data, you might say, well, all things being equal, the placebo looks safer than the SSRI. So if I have to take something, I prefer to take the placebo. Then in the middle there, you've got a much smaller trial, much fewer patients, but much more suicidal events. Sorry, I should have told you the 10 events up on line 2 are suicidal events. So the 48 and 40 are suicidal events. And again, it's pretty grim. It's a little harder. I mean, it isn't as clear cut in terms of which to pick, but all things but equal, you'd say the placebo looks a bit safer than the SSRI. Now, here's the magic. We just add lines 1 to 3 and lines 2 to 4, and we get to lines 5 and 6, where all of a sudden Paxil looks safer than the placebo. If you're going to be rational, or if you're going to be a doctor being rational, you'd go for Paxil rather than placebo. This trick is one that GSK played on FDA. They submitted the document that you see here, which you're not going to be able to read easily. That's why I've rounded up the figures on the previous page. Uh, so there's no need to dig too deeply into these. This is just illustrating that I'm not making this all up. This is from an actual document GSK did send in to FDA, expecting FDA to be fooled, saying, look, when we put all our trials together, we get a situation where paroxetine looks safer than placebo. So you can't put black box warnings on this drug. So, but that's not the only thing I want you to pick out on this slide. The only thing I want you to pick out is on the right-hand side, there's a column which has the word OR on it, and then after that, brackets 95% CI. That means confidence intervals. So this is the infallibility bit. And FDA and companies claim to have infallible knowledge about what the drugs do. That when we look at whether we can produce a change on Paxil for the good, we insist that there must be 95 bullets in a 100-chambered gun before we say that this drug works. Works on rating scales, doesn't mean work on actually saving lives. There's more people dying on Paxil and other SSRIs than on the placebo. But we also apply the same logic to the adverse events, the suicidal events. We say that unless there's 95 bullets in the 100 chambers of the gun, then the gun is not loaded. It couldn't have caused this event. And we don't actually check, we don't count them. We trust the company when they say, we looked over it and there didn't appear to be 95 bullets there. In fact, they didn't collect the data very, very well. In fact, they often told people like me not to collect the data. But anyway, so a lot of medical statisticians told companies and FDA, this is crazy thinking. It doesn't apply to medicine, certainly not to the safety of drugs. You should be using confidence intervals instead, and that's the CI bit there. And let me show you. If you take the figures from GSK's document there, from major depressive disorder, and draw a confidence interval, as you see here in red, you get the curve that you see here, which is widely spread. And this isn't we're not being as confident here as we'd like to be. Over in the middle there of the graph, you see this black line. And that's the 1.0 line. And all of the data to the right-hand side of that says the gun is loaded. If you look at a little bit of red to the left-hand side of the line, that's a little bit where GSK is able to say the gun is not loaded. There's only 94.5 bullets in it, so it's not loaded. And we know infallibly that this is the case. And the usual story with confidence intervals is if you add a few more patients and events into the mix, you tighten up the confidence interval. And that's what GSK have done here with the yellow curve that you see. It's much, much tighter, but you won't find this in books anywhere. In books that deal with statistical issues anywhere. And what's happened is that the curve, this is all of the patients put together, the ones who have major depressive disorder and the ones who are GSK called intermittent brief depressive disorders. The curve has moved right over to the left-hand side of the line, which means not only is the gun not loaded, but you can leave it out of the gun cabinet, you can leave it with the safety catch off, and the kids around the house aren't going to be at any risk at all. This shouldn't happen, but it does happen because these tests have no basis in biology or human reality or whatever. They're not delivering the objectivity they're sold as delivering. They're not delivering the infallibility because they're virtual. They're nothing to do with real life, real human life. Now, the man you're seeing over there on the right is a man called Ian Hudson. We'll call him Cardinal Hudson. And he's testifying in a case of a man called Don Shell, who, like Woody, has a few nights poor sleep, gets put on Paxil, and 48 hours later shoots his wife, shoots his daughter, shoots his granddaughter, and shoots himself. And Cardinal Hudson says to the jury of plain people in Wyoming, uh, GSK practice evidence-based medicine and use randomized controlled trials. And I can tell you, Paxil didn't cause this. Not only that, but Paxil has no adverse effects at all. The jury looked at him and clearly thought he was nuts, and that Paxil, GSK, had been responsible. Don Shell did not murder his family. GSK were responsible for this. Cardinal Hudson, for his sins, shortly afterwards, a few years later, became Pope Ian Hudson, the head of Britain's version of the FDA. And the point I want to make here is that the kind of thinking you've heard from Hudson here has become entrenched and is still entrenched at the top of our healthcare Vaticans. But that what we're dealing with is models. We're not dealing with real world stuff. It's a bit like rating scales. And before we leave this area, let me just show you one more thing. I mentioned earlier the CBT study we did and talked about rating scales being in the virtual world, not the real world. And in depression trials, we can use the Hamilton Depression Scale. And on in this Zoloft trial from 1983 of patients who are depressed, we have a man on the Hamilton scale doing very well and is going to be a good trip on Zoloft, and is going to help this drug be licensed. But in actual fact, when someone who's clearly met him before and can spot there's a difference here, chats to him, doesn't use a rating scale, chats to him, they find out that, he may be doing better on the rating scale, but in real life, he's thinking about killing others, maybe his wife, and himself. He's dropped out of the trial, as you might expect, but you won't expect that they dropped him out of the trial and coded him as nausea. That FDA have no real way to know what's going on here. Other people have dropped out of Pfizer trials who have become so agitated on treatment they poured gasoline on themselves and set fire to it, trying to kill themselves, but didn't die until 5 days later in hospital. They died from their burns, and they're coded as burns, not suicide. So, in terms of FDA having any real idea of what went on in these trials, not likely. So that brings us to this point here, and I'm sure you'll all recognize these are the witches from Macbeth. And Macbeth is a tragedy. That means the hero has a flaw, and it's the flaw in him that is his undoing. The witches clearly play into it. I'm going to tell you how. Let me begin, though, first by bringing into the scene, into the frame, the man who invented randomized controlled trials called Austin Bradford Hill. And Hill, 20 years after the first one was done, and when a few were being done now because FDA were beginning to require them, Hill, talking to a bunch of doctors, said, look, randomized controlled trials tell me nothing about how to treat the patient in front of me. That the best way to work out what a drug is doing to a doctor, the best way to evaluate the drug and what is doing to the patient is to interview them, talk to them. He said, if we ever get to the point of thinking randomized controlled trials are the only way, are the gold standard way to evaluate drugs, we will have gone stark raving mad. Another way to put this is a bit like all drugs are poisons and the art of medicine is bringing good at the use for poison, is randomized controlled trials generate ignorance. You're looking for one of the 100 effects a drug has, you're focusing on them, and you're ignoring all the others. You're generating ignorance. And we've got to be very careful about how we use whatever bit of knowledge we might get out of that process. We can't assume that we know much because we don't. Once you hear all that, and once you hear the fact that the cardinals and popes of evidence-based medicine and all around the place are saying randomized controlled trials are the gold standard way to evaluate a drug, you realize we're up against something else. We're not up against a big pharma who are making drugs for our needs, making drugs to save lives, because Goldman Sachs has said that's not a good business model. We're up against big propaganda who are making treatments for our first world discontents, they're generating our wants and our discontents and offering treatments for it. We've got randomized controlled trials creating a trans medicine where we used to have medicine, creating probity blockers where we used to have drugs that we knew what they did. So this is a tragic situation, and the issue for all of us is how is the tragedy going to unfold? And well, I mean, who in the case of Macbeth, the witches said, "Look, you're fine until Birnam Wood moves to Dunsinane," and Macbeth and his wife figured there's no chance that's going to happen. They've said to Lilly and Pfizer and the other companies, "You're fine," while everybody believes in RCT gold. And Lilly and Pfizer have all said, "Hey, that's wonderful." In the case of turning the problem we've got around, one of the groups who might do it will be doctors, except, you know, doctors have been trained by pharma to, like us, to defer to FDA. Rather than them getting involved and thinking about trying to keep us safe, they defer to FDA. Uh, they're believing the drugs are 100% effective and safe, but if they are, these things could be available over the counter, and we might be a lot safer if that were the case. They are increasingly being prescribed by nurses who are much cheaper prescribers than doctors. So doctors are sleepwalking to oblivion. And it's not clear they're going to play much part in helping us sort out the problem. Uh, you might say, well, it's not doctors' jobs to do the science and keep us safe, that FDA do that. And that's what companies are hoping you're going to think. But FDA do something rather like the Federal Aviation Authority, FAA, who license the plans for planes Boeing give them. But FAA don't keep you safe when you're up in a plane going to New York. It's the pilot that keeps you safe. And she keeps you safe because she has an incentive to keep you safe, which is that if you don't get to New York, she won't get there either. Doctors don't have the same incentive. It's actually the other way around. If they take your side in all this and try and keep you safe, they risk losing their job. If you're on a healthcare plane these days and the door blows off it, chances are, rather than try and stop the plane or turn around, etc., the doctor and the crew are going to throw you out the open door for spreading misinformation around the place, for threatening, causing people to be anxious when they really shouldn't be. So, if you're prescribed a drug at all these days, it's probably a good idea to think about bringing along a parachute. So, does anyone have an incentive to keep us safe the way pilots do? And actually, they do. It's an interesting answer, though. When we think about new drugs, getting new drugs, things are going to work, make us healthier, etc., etc. We think about the free market, and businesses have an incentive to find the things that keep us safe. But I've told you that they really don't. We also think about social forces, and health has been something that social parties and liberal parties on the left have tended to be more concerned about than business people have been. At least that's the perception. But really, neither of them have played as big a part in creating modern medicine as the military have, as the US military in particular have, because the military have an incentive. It's the armies that have the healthiest patients who lose least men or women these days to disease or injury that win wars. It's not just the weapons you have. And the US military created modern surgery and most of modern medicine through to the 1950s. And in the 1950s, when the pharmaceutical industry came in on things and really helped out a bit, we got a wonderful generation of new drugs, which were the best in class. We got antidepressants, antipsychotics, benzodiazepines, well, minor tranquilizers, antihypertensives, hypoglycemics, steroids, chemotherapies, almost every class of drug you care can think of appeared during the 1950s, and the best in class appeared without a single RCT, based on doctors interviewing patients and examining patients, seeing what happened to the patients. We didn't have an RCT in sight, and the drugs have got weaker and weaker. And you see, the problem with all that has been we've now got a polypharmacy pandemic, which kills you. I mean, correlated with the number of drugs people take these days is life expectancy. And in the US, it's fallen. In the 1960s, it was the best in the world. It has now fallen. The US is down around 80th in the world, or maybe even lower. Reproductive replacement rates have fallen through the floor. Disability rates have gone through the ceiling. And armies to win wars need more troops. They need them healthy, and they need to be able to put things right when things go wrong. And they have an incentive. For the US military in particular, if they don't win, they're going to be replaced by the Chinese military. That's a very real prospect. So they've got an incentive to look at the systems not working right in a way that almost no one else has, and the power to put it right, the power to chop down Burnham Wood and take out Google Maps and work out what's the quickest way to Dunsinane. That's where Macbeth's castle was. So keep an eye on this space. When Macduff's army got to Dunsinane and Macduff got into Macbeth's castle, he met a scornful Macbeth who said to him, I'm not worried. No man born of woman can harm me. And Macduff growled, I was from my mother's womb untimely ripped. You don't need to be a man, and you don't need to wield a sword to do what Macduff then did. Kim Witzak faced Bob Temple and told him Woody's story in detail. And Temple, knowing he was using an insulting word, said to her, Woody is an anecdote. Since then, Kim has campaigned on the platform of we are not anecdotes. And one of the options these days is to get t-shirts made and things like that with we are not anecdotes or I am not an anecdote on them. And I'm going to show you how prescient that was. It's taken me a long time to get to grips with just how good this is. And I can't show you the next slide yet. I'm just going to tell you. Let me take you back to 1606 in London. And Macbeth is playing in the Globe for the first time. People get exposed to the story. 54 years later, in a room a mile away from the Globe, a bunch of men, they were all men back then, created modern science. What they did was they arranged to have a series of meetings weekly or whatever, where they would run an experiment. People were invited in with different points of view. You were told you had to leave the Bible and the Quran and every authority outside. You've got to come in and watch an event, a single event, not hundreds of events randomized into a controlled trial, a single event which generated observables, like a dog, a young dog's blood being transfused into an older, feeble dog, and the older, feeble dog looking better. Looking down what we would now call a microscope of what appeared to be teeny living creatures, which we called microbes then and germs now, maybe, and things that people hadn't seen happen before and come to a view about them. These views the experiment, the event, got written up in case reports, which were kept in the archive. At that time, there were no medical journals. They were 200 years in the future. There were no statistics applied to the evaluation of drugs. That was 300 years in the future. This is the process that helped us land men on the moon, that helped us increase life expectancy, that helped us decode the human genome. It's a process of observing and coming to a consensus. Now, in the middle of all this, we've now got a situation where we're going to bring Kim and Woody into this room. If we're going to work out what happened to Woody, you need Kim there who can see him from the outside. You ideally need Woody himself there. You need Woody's mother, who told Kim later, he was very worried. He was having thoughts about harming you. I forgot to tell you back earlier, when the Tobin case, Don Shell's case, happened, the very same week, there was a case in Australia, a man called David Hawkins, who had been put on Zoloft, Woody's drug. And Hawkins had been like the man in the Pfizer clinical trial that you saw, agitated without people being able to see it, and had taken more Zoloft. Now, you're not getting all the details of the case that would make it clear to you why the views about this case that we have appeared, but he killed his wife. And the prosecutor in the case, who never lets anyone go, their job is to make sure you get the death penalty if at all possible. And the judge, without going to a jury, they said there's no point going to a jury. It's obvious. The Zoloft killed his wife. He didn't. And they let him walk out. So he had been put on Zoloft for a few nights' poor sleep. Would he have been put on Zoloft for a few nights' poor sleep? He was thinking maybe about killing Kim. And maybe this is why he suicided. But it's not because of he had thoughts about killing Kim, but the drug was somehow causing it. And he felt increasingly powerless to resist these things, as people do. So we need them there. We also need someone doing well on Zoloft. We need someone from Pfizer who, after all, concluded Zoloft can do these things 40 years earlier. We need Bob Temple there. We need a bunch of people with different points of view. We need Chris Armstrong, his doctor there, with different points of view to come to a consensus about what we think has happened in this case. And then it will be written up in a case report. Now, just to show you how badly wrong we've gone, I know for certain that if a case report like this was written up, no medical journal, the New England Journal of Medicine, the BMJ, or etc., would ever publish it. They'd be scared, they'd be sued if they'd published it. This is the purest science on earth. It's exactly how science began and should be still happening, and our medical journals would not publish it. I will only believe that Birnam Wood has arrived at Dunsinane when I see a case like Woody's reported in the New England Journal of Medicine or the BMJ. Otherwise, don't believe anything has really changed. In the case of Chris Armstrong, he's a very interesting person in there in the mix. He felt terrible about Woody's death. He concluded the drug had caused the problem. Uh, and, he seemed to have been a very decent man. But if he was to say to us, look, you've got me involved in this scientific exercise. I'm not a scientist. I didn't go into medicine to do science. I went into medicine to care for people. I think the answer that comes to me anyway, which is, I've got from a load of the people linked into risk.org, is that, look, I want you to try I mean, this is you as Woody or you as Kim or as me as whatever, when you come in to see a doctor like Chris Armstrong or me, and you've got an adverse event on a drug, your message to them is, you know, I want you to engage in listening to me and try and come to a consensus with me. And I don't mean try and persuade me to believe something you believed a week ago before I came into the room. I don't want you to get me to follow something you think is the truth. I want you to help me work out what's the truth about what's happening to me. And if you can't do that or are unwilling to do that, forget science. I don't see how you can care for me. So we can't have the meeting we just had, not because journals won't publish, but because Woody is dead and other people are dead. And it's not science to bring Woody's ghost into the room, but let's do that. Hamlet's father's ghost turned up. and told Hamlet what had happened to him. He said he was poisoned by someone he should be able to depend on. And he wasn't poisoned by a pill being put into his mouth. He was poisoned by stuff poured into his ear. And that's what happened to Woody. Hamlet responded to his father's ghost and said, "Revenge, revenge. I'll sweep on swift wings to your revenge." But Hamlet's tragedy was he became indecisive. This is the flaw. He said, "The time is out of joint. Oh, cursed spite, that ever I was born to put it right." That was Hamlet's tragedy. It's our story, and it's your story. Thank you.